Well, thank you for your introduction, Professor Kim, members and guests. It's my great pleasure to be invited here to talk on updates of consensus guideline for the management of IPMN. Actually, IPMN and MCN, but I would omit MCN side. After 6 years of accumulation of evidences, the guidelines have been revised last year and published in the Pancreatology. The illustrations to show the type of classification are used on the front page of this issue of the journal. My talk today will focus on the points of the major changes of these Fukuoka guidelines on the IPMN side, not on MCN side. The mixed type category has been preserved again for the moment. The point changed in the revised guidelines is the threshold of ductal dilation for the diagnosis of main duct type IPMN. The threshold of the main duct has been lowered to more than 5 millimeters to increase the sensitivity of the diagnosis of the main duct type IPMN. The definition of malignancy of IPMN has been variable, hampering the comparison of data among different institutions and different reports. We recommend abandoning the term carcinoma in situ in favor of high-grade dysplasia, reserving the descriptor of malignancy for invasive carcinoma only, as outlined in the recent WHO classification. However, I personally believe in the presence of carcinoma in situ, but abandoning this term is a current trend of WHO pathologists. Every Japanese pathologist who frequently look at early gastric mucosal cancer and its natural history knows very well that mucosal gastric cancer eventually shows a minimal submucosal invasion and then grows up to invasive carcinoma in a couple of years or so. So in my opinion, carcinoma in situ does exist, and this should be included in the malignant category. However, as a consensus guideline, especially international consensus guideline, we had to adopt this definition that you see in this slide. Criteria for identifying malignancy in branch duct IPMN, called Sendai criteria, have been revised this time. High-risk stigmata have been defined again to include jaundice, contrast-enhanced solid component, the size of the main pancreatic duct equal to or more than 5 millimeter, 10 millimeter, I'm sorry. The presence of solid components or mural nodules is the most reliable predictor of malignancy. All cysts with high-risk stigmata, as you see in this slide, should be resected immediately if the patients are fit. This is an algorithm in the Sendai guideline, former guidelines, where the cyst size more than 30 millimeter was one of the indications for resection of branch duct IPMN. But it was a kind of notorious to decrease the specificity of the diagnosis of malignant change. We did recognize this problem at that time in 2005 and inserted this sign here, see clinical question 3B, in this algorithm. Clinical question 3B in the Sendai guidelines was, should all branch duct IPMNs be resected, the overall lower prevalence of malignancy in branch duct IPMNs and the very low likelihood of invasive cancer in small cysts raise the possibility of management with careful observation in asymptomatic patients. More data based on pathological studies of branch duct IPMN more than 30 millimeter in size and without main duct dilation or mural nodules are needed to determine if all branch duct IPMNs more than 30 millimeter should be resected immediately. But this insertion has been almost always ignored. So Fukuoka guidelines have made a different category of worrisome features to promote further evaluation, and the cyst size greater than 30 millimeter has been moved to this category, worrisome features. The other worrisome features include thickened and enhanced cyst wall, main duct size of 5 to 9 millimeter, mural nodules without enhancement, main duct stricture with upstream dilation, and lymphadenopathy. All branch duct IPMNs with these worrisome features should be further evaluated by endosonography. If no worrisome features are present, no further initial workup is recommended, although the surveillance, continuous surveillance is still required. So this is an algorithm for the management of branch duct IPMN in the revised international consensus guidelines. You see the high-risk stigmata here and the worrisome features underneath, but I won't go through this in detail because it's too busy. The Fukuoka guidelines refer to the roles of cyst fluid analysis by EUS-FNA and ERCP in the management of IPMN. Cyst fluid analysis is still investigational, but is recommended for evaluation of small branch duct IPMNs without worrisome features in centers with expertise in EUS-FNA and cytological interpretation. Special expertise is necessary to interpret the cytological result accurately. Distinction of branch duct IPMN from a small oligocystic serous cystic neoplasm is challenging and may require EUS-FNA with cyst fluid CEA determination, which is very low in SCN. Routine ERCP for sampling of fluid or brushing in the IPMN is not recommended and should only be used in the context of research. However, one study from Japan by Hirono published in Annals of Surgery showed that the mural nodules more than 5 millimeter and a cyst CEA level in the pancreatic juice more than 13 nanogram per ml were independent predictive factor associated with malignancy. In fact, ERCP for sampling of the pancreatic juice cannot be performed in most Western countries, but may still have a significant role in the diagnosis of malignancy in branch duct IPMN. Now, in regard with the indication for resection of IPMN, resection is recommended in all surgically fit patients with main duct IPMN. If the margin is positive for high-grade dysplasia, additional resection should be attempted to obtain at least moderate-grade dysplasia. The indications for resection of branch duct IPMN have become more and more conservative. Branch duct IPMN more than 3 centimeters without high-risk stigmata can be observed without immediate resection, particularly in elderly patients. Pancreatectomy with lymph node dissection remains the standard treatment for invasive and non-invasive IPMNs. Focal non-anatomic resection or anatomic resection without lymph node dissection or splenectomy may be considered for patients without suspicion of malignancy, but carries a risk of possible leakage of mucin and higher incidences of pancreatic fistula and recurrence. Low-grade dysplasia and possibly high-grade dysplasia of IPMN may be a good candidate for laparoscopic surgery. EUS-guided ethanol ablation with or without paclitaxel cannot be recommended for patients with branch duct IPMN outside of a very closely monitored research protocol. Regarding the histological aspect of IPMN, the type of invasive carcinoma, colloid versus tubular, has major prognostic implications, with colloid carcinoma being characterized by intestinal differentiation and a better prognosis than tubular carcinoma. Minimally invasive carcinoma is often used with variable definition. Instead of minimally invasive carcinoma derived from IPMN, it would be more appropriate to stage invasive carcinoma with the conventional staging protocols and further substage this minimally invasive carcinoma by T1 category, divided into T1A, T1B, and T1C to make accumulation of data possible between and among the different institutions. The histological subtypes of IPMN have clinical pathological significance and were adopted in the Fukuoka guidelines. I will not tell about the detailed features of mucin immunohistochemistry of each type here, but rather clinical features or of frequent types. The gastric type is typically low grade with only a small percentage developing into carcinoma. However, if a carcinoma does develop, it's usually of the tubular type and very aggressive. Large intestinal type IPMNs can have invasive carcinoma of the colloid type with indolent behavior. And rather rare oncocytic types forms a large non-invasive tumor and tend to be misdiagnosed as mucinous cystic neoplasm. Most infrequent pancreatobiliary type has a high malignant potential and shows very aggressive behavior after malignant transformation. As you see in the table reported by Mino Knudsen, the histological subtypes are correlated with macroscopic types of IPMN. Gastric type is frequent in branch duct IPMN, and intestinal type is frequently of main duct type. The high frequency of combined type here is due to the MGH's policy to favor histological type classification. If clear high-grade dysplasia or invasive carcinoma is present at the margin of frozen section analysis during surgery, further resection is warranted. Although moderate-grade dysplasia or low-grade dysplasia does not require any further resection. As additional resection is often necessary in patients with IPMN, all patients should be informed preoperatively about the possibility of total pancreatectomy. After I reported a patient with carcinoma in situ concomitant with benign branch duct IPMN in 1997, there have been a substantial number of reports describing synchronous or metachronous combination of pancreatic cancer and benign IPMN in the same patients. A distinction between pancreatic cancer derived from an IPMN and pancreatic cancer concomitant with an IPMN is proposed with regard to the topological relationship and histological transition, although the distinction sometimes remains undetermined in advanced cases. This is the first case in the world where I found carcinoma in situ or high-grade dysplasia concomitant with benign IPMN. After I confirmed that the body or tail of the pancreas is the origin of a positive cytology by endoscopic balloon segmental cytology to localize the carcinoma in situ preoperatively, we performed the left pancreatectomy for this patient. The origin of the positive cytology was confirmed again by segmental cytology during surgery after cutting the neck portion of the pancreas, and complete histological examinations revealed the carcinoma in situ in a branch close to the small benign branch duct IPMN. And this is the second patient I found 1 year later. During the ERCP of branch duct IPMN, the pancreatic juice collected preoperatively proved to be malignant. There was carcinoma in situ in the main pancreatic duct adjacent to the communicating branch of a benign branch duct IPMN. These are patients who underwent pancreatoduodenectomy for pancreatic cancer concomitant with IPMN. Number 13 is an example of metachronous development of pancreatic cancer after resection of a benign IPMN. And these are patients who underwent distal pancreatectomy. In the patient number 27, we found a carcinoma in situ during workup of an IPMN in the tail of the pancreas. We did distal pancreatectomy, but he developed advanced cancer again 7 years later. So the development of a new carcinoma in the pancreas remaining after resection of IPMN is another concern in the management of IPMN patients. This panel illustrates those undergoing total pancreatectomy and those with unresectable cancer concomitant with IPMN. Until March last year, we have experienced 43 patients with concomitant pancreatic cancer in 405 consecutive patients with IPMN. Most of them are branch duct type, but main duct type and mixed type are not exception. And this phenomenon is recently drawing more attention and it's being reported that 9.2% to 2.0% of patients with branch duct IPMN had pancreatic cancer distinct from the IPMN. The incidence of the carcinoma development has been shown to be below or around 1% per year. This means that you are supposed to find out one patient with pancreatic cancer in your clinic every year if you have 100 patients with branch duct IPMN on follow-up. However, I don't know yet the adequate method or interval of surveillance of IPMN to diagnose the cancer development in a very timely phase. This year, a very impressive data on this issue have come out from Japan. Kamata and his associate followed up 102 patients with branch duct IPMN for a median of 3.5 years, a relatively short period, by performing EUS and other imaging studies every 3 months. They found concomitant pancreatic cancer in the 7 patients by endosonography, while there was no single patient who showed malignant changes of their branch duct IPMN. More interestingly, they examined these 7 patients by CT and MRI right after the diagnosis, but CT and MRI could demonstrate the presence of concomitant cancer in only half of them. These data have a very important implication on the significance of endosonography in the diagnosis of pancreatic cancer arising in patients with IPMN. So the Japan Pancreas Society is now doing a prospective multi-center study to clarify the true incidence of pancreatic cancer and the best method and interval of surveillance in patients with branch duct IPMN. More than 2,000 patients with branch duct IPMN are planned to be registered in a computer of my university through a website right after the initial CT, MRI, and EUS. CT or MRCP and blood test will be performed every 6 months, and the EUS will also be added every year. In 5 years from the end of the 2-year registration, we will know the true incidence of concomitant pancreatic cancer and how to diagnose it as early as possible. So my conclusions are several points have been revised in the Fukuoka consensus guidelines. Threshold of ductal dilation has been lowered to 5 millimeters. The management of branch duct IPMN has become more and more conservative. Histological subtypes have been brought into attention in the guidelines. The more attention has been paid to the development of concomitant pancreatic cancer in patients with IPMN. So these are the updates of the consensus guidelines for IPMN management. Thank you for your attention.